Welcome everyone to today's workshop, Integrating Healthcare and Housing in CalAIM, Anthem's Lessons Learned. So it's the final workshop of the conference, so thanks everyone for sticking with it, and hopefully it's going to be a good discussion today. So my name is Stefan Gonzalez. I'm with LaSar Development Consultants. We are a mission-driven consulting firm that's really focused on ending the housing and affordable housing and homelessness crisis. Sorry, butchered that one. I'm going to be the moderator for today's session and will help field the Q&A portion of the workshop. So super excited to have the different panelists here today. LaSar Development Consultants really played a unique role in a lot of this work. We supported Anthem with their strategic planning around housing and homelessness initiatives. And then we also supported the implementation of some of the various Anthem pilots that you're going to hear about in just a second. So in today's workshop, we're going to look at the intersection between healthcare and housing and homelessness, and then we're going to explore some of the lessons learned from Anthem's housing and homelessness strategy, which consisted of various pilots across the state of California that informed Anthem's rollout of CalAIM. So CalAIM, which some of you might be familiar with, is a new Medi-Cal initiative launched in January 2022 by the Department of Healthcare Services to address many of the complex healthcare challenges across the state. So we have a hybrid format today. So for those of you that are attending online in the virtual audience, you'll have the opportunity to ask questions in the chat. And then at the end of the session, we'll have that Q&A, and we can get to some of those questions. So looking at the agenda for today, quick welcome and introductions, and then briefly I'll kind of set the stage. Then I'm going to pass it to Chris Kuntz. Chris is going to provide an overview of Anthem's kind of evolution of their housing approach, an overview of the various housing and homelessness pilots, and then talk through how that work and those pilots impacted their CalAIM implementation and some of these future initiatives. Then we're going to hear from Miguel Perez from Kings Tulare Homeless Alliance. Miguel will describe the homeless continuum of care perspective and their expanding healthcare and homelessness partnerships and collaboration, and really focusing on one of Anthem's pilots in those two counties. And then we're going to hear from Samantha Earnshaw from Lutheran Social Services of Northern California, from that kind of provider, community-based organization perspective. LSS served as the housing problem-solving provider in Sacramento County for the Anthem pilots. And we'll hear about their evolution as an organization integrating healthcare and homelessness and their experience with the Anthem pilots and CalAIM. And then finally, we're going to get questions from all of you and from the virtual audience for our panel. So quickly with some panel introductions, and I'm going to keep it as brief as possible. Chris Kuntz is the housing manager for Anthem California. His role really supports the operations, the business strategy, and the alignment of Anthem California for housing and homelessness programs, and is really integral to Anthem's rollout of CalAIM. He's got extensive experience at both the COC level, strategic homelessness planning work, and at the service provider level. We also have Miguel Perez, Executive Director of Kings Tulare Homeless Alliance. He provides regional leadership on the issue of homelessness across both counties and has extensive experience in affordable housing sector as a community-based organization leader. And then finally, Samantha Earnshaw with Lutheran Social Services. She manages the CalAIM programs and also previously managed the Anthem pilots in Sacramento County. And she has extensive experience, decades working in direct homeless services. So just to quickly set the stage around housing is health. So I wanted to spend a couple minutes to kind of set the stage. Across all of these three presentations, you're going to hear how housing and health are really tied together. And without stable housing, healthcare outcomes are really difficult to achieve. And so we know that homelessness is really associated with enormous health inequities. So that's shorter life expectancy, higher morbidity rates, greater usage of emergency services. And so for people experiencing homelessness, and social determinants of homelessness and health inequities really are so intertwined together. And so we get to the place really on the screen, right? Housing is health. So treating homelessness as a combined health and a social issue is really going to be critical in improving the health outcomes of people experiencing homelessness. And so today we're going to explore the initiatives that bring together health and housing. So something that you'll hear from our panelists today is the concept of social determinants of health. I won't really get into it too much today because I'm sure many of you are kind of familiar with this. But it's the conditions in which people are born, grow, live, work, and age that really shape or impact their health. Some of those factors include economic stability, neighborhood and physical environment. That's where you see housing, education, food, community, safety, and social context, and healthcare systems. So homelessness and health. Ultimately, housing and healthcare really work best when they are applied together, and it's going to be essential to preventing and ending homelessness. So healthcare services are really more effective when a patient is stably housed, and in turn, maintaining housing is really more likely if proper healthcare services, right, are delivered. So they're really coupled together. The stresses of living on the streets without stable housing often creates new health problems and exacerbates existing ones. And recovery is also far more difficult when those who are experiencing homelessness, if they don't have a stable place to stay. And this really underlines the fact, kind of that last bullet point, that healthcare really cannot be a substitute for stable housing. So in recent years, as the healthcare and the homeless service sectors have better understood social determinants of health, there's been a corresponding shift from a more transactional patient-provider experience to one that is more holistic, whole person care approach. So whole person care is something that you'll hear from our panelists today, is a patient-centered approach that really strives to deliver physical, behavioral, emotional, and social services required to improve care coordination, well-being, and health outcomes. So some of the common strategies in a whole person care approach include behavioral health integration, you have coordination with health home efforts, the use of non-traditional healthcare workers, and also providing additional services that historically have not been offered as sort of your standard benefits package, such as peer supports, home modifications, non-emergency transport, and housing supports, which we're going to hear about today. So looking at some past initiatives across the state of California around housing and healthcare integration, in 2016, California began the whole person care pilots, and these pilots spanned across 26 counties and aimed to really increase integration and data sharing among county agencies, health plans, and community-based organizations, targeting a number of sort of high-risk populations that have complex needs. One, for example, is individuals experiencing homelessness. Health Homes program began in 2018, and it complemented many of the whole person care pilots, which provided care coordination for Medi-Cal managed members with complex medical needs, chronic conditions, or were experiencing homelessness. And so really both of these initiatives increased integration and data sharing between the homeless and the healthcare sectors and laid the groundwork really for the state rollout of CalAIM. So CalAIM, California Advancing and Innovating Medi-Cal, is a recent initiative by the Department of Healthcare Services, DHCS, that really significantly transforms California's Medi-Cal program. the state's version of Medicaid, which provides health insurance to over 13 million low-income residents. So CalAIM takes the state's whole person care approach and takes that statewide, recognizing that some of the most effective interventions are actually ones that are non-clinical. So quickly looking at some of the CalAIM components. So CalAIM adds new programs and reforms existing programs, all focused on creating this whole system, person-centered strategy. And so I just want to highlight two really quick that we'll get to also in the presentations. The first is enhanced care management. So this is a new benefit that includes care coordination and comprehensive care management services to address the clinical, the behavioral, and the social needs of Medi-Cal members or enrollees with complex needs. So those are going to be people experiencing homelessness, high utilizers of emergencies, for example. And then secondly, I want to highlight community supports, or in lieu of services, or ILOS. There's a lot of different acronyms that are kind of get thrown around. Medi-Cal managed care plans partners are going to begin to offer community supports, such as housing navigation services, housing supports, which play really a fundamental role in meeting enrollees or Anthem members' need for health and housing related services that address those social drivers of health. So the kind of workshop objectives for today, we're hoping to explore that connection between healthcare, housing, and homelessness to really understand how Anthem's pilots and those pilot projects informed their implementation of CalAIM. And then also hopefully to share some community examples of healthcare sector collaboration to prevent and end homelessness. So again, there's going to be an opportunity at the end of the session to ask questions, and we'll get the questions also from the virtual audience. So with that, I'm going to pass it to Chris to kind of present on some of CalAIM, or some of Anthem's work. Go
ahead. All right. Thank you, Stefan, for the framing. And I would say also Jeff Olivet with USICH in the plenary did a really good job of talking about that intersection of healthcare and housing and homelessness. And I think Jeff said it right, partnership. Partnership was the theme that rang true to me when he was talking about bringing these two sectors together. So, but hi everyone, I'm Chris Kuntz, and I am with Anthem Blue Cross. I'm relatively new to Anthem. Most of my experience has been working on homelessness and housing, and so I feel kind of like a undercover, housing homelessness person at a health plan right now. So, but it's been a wonderful opportunity to join the health plan here in California. I'm going to talk about some pilots, and I hate to say, I was here about 10 years ago. I was working on a frequent user pilot in San Diego. And it's kind of funny now, 10 years later, still talking about housing and healthcare pilots. But I think we've arrived. I think we're finally to a place where we're no longer going to start, keep talking about pilots. We're going to start talking about really kind of system integration and partnerships, and this is just how we do things from now on. So, and I think yesterday in the plenary, one of the panelists said something like, if you haven't met your managed care plan, it's time. So hi everyone, Chris. I'm with Anthem. I'm probably one of your managed care plans. And so, real quickly, Anthem. So obviously, Anthem's a big national health insurance company. We're in a lot of states across the country. I have no idea what most of Anthem does. My health insurance before I was at Anthem was Anthem Blue Cross through my wife's school district. But I'm here mostly to talk about what we do with Medi-Cal. All right, so we are in 29 counties here in California. So you can see on the map there, most of our blue areas. We have a big presence in the Central Valley. Tulare County, Kings County. You're going to hear from Miguel. Fresno, all the way up here in Sacramento. We have a presence in Los Angeles. We have a presence in the Bay Area, so San Francisco, Alameda, Santa Clara, Contra Costa. So we have a pretty wide footprint of providing Medi-Cal in California. And so when we look at where I'm kind of situated in the Anthem's world is within special programs. So part of special programs are all the things that are kind of everything else, in addition to healthcare. So all the various waiver programs, our community health worker programs, palliative care, health homes, all of our housing work falls under a division at Anthem Medi-Cal called special programs. So Anthem, I think even though we're here, we're presenting at a housing conference, and we've been working on housing for a while. I think we still have a long ways to go as a health plan, but I would say our evolution really started several years ago. I think with this really acknowledgement, understanding, right, like Stefan was saying, right, and Jeff said earlier, right, that housing is healthcare. We took that to heart. We knew that if people were going to have good health outcomes, we're going to see changes in cost and utilization, right? That housing had to be that stable place for folks to be able to address those health concerns. So we talked about whole person care piles, we talked about health homes, but in 2017, Anthem, I think unusual for a health plan, right? Hired housing staff, had dedicated staff, come work for the health plan. People that had backgrounds, working in housing, working in homelessness, work for local providers for Continuum of Care, joined the Anthem team. In 2018, Anthem worked with Lasar and team and created a housing strategy, a homelessness strategy, right? What were we going to do? What were we going to, how do we actually address housing? What is homelessness and housing? So, and then what I'll spend most of my time today is on, from about 2019 to 2021, we did various pilots across the state. And I think right now where we're at is that top one that says CalAIM planning and implementation. I think that's where we're at right now. It is a big, change and challenge and undertaking for the health plans across the state. And hopefully what we get to in the future, right, is this really enhanced partnerships and integration. And I'm going to talk a little bit about the new housing and homelessness incentive program, HIP. So real quickly, Anthem's strategy, this is one we did in 2018. It provided a roadmap for us. What were some of the things, strategies we're going to do? What were, that kind of really helped shape what we thought about with our pilot programs. But you can see these 7 strategies. It's everything from best practices, housing first, harm reduction, et cetera, right? Trauma-informed, creating partnerships, looking at prevention all the way through, being a part of supportive housing and affordable housing development. And lastly, data and data integration. So none of these things, if you've worked in the housing and homelessness sector, none of these strategies are brand new ideas. These aren't shocking, right? And that was intentional. The idea was to align our health plan strategies with housing and homelessness strategies. Why recreate the wheel? We need to be part of that system. So let's make sure that our strategies of the health plan really align with where the housing and homelessness sector is moving to. All right, so the pilots we did, I'm going to talk about 4 pilots that we did across the state. We did some permanent supportive housing pilots. We did a statewide housing flex fund. We did some housing problem solving, housing navigation services, and then we did some temporary housing programs, shelter programs I'll talk about. But the purpose of the pilots was really to, in the immediate, just support Anthem members who are at risk of or experiencing homelessness. Provide some, supports, services that we could roll out to our members, and also our care coordinators. Our care coordinators are on the front lines working with homeless members, right? And they don't have a lot of tools in their toolbox. So it was also to be able to provide our internal staff at Anthem some opportunities, some services that they could refer members to. But I would say a good chunk of the purpose of the pilot was start to begin to develop those relationships, start to build the partnerships, start to build the network of service providers that kind of have now transitioned into some of our service providers here with CalAIM. We wanted to test strategies, we wanted to evaluate our investments, were they working, what could we do better, et cetera, and like I said, prepare for where we are today with CalAIM. So this is a lot on a slide, and I apologize for that, but I'll talk about 3 of our supportive housing pilots that we operated across the state, one in Los Angeles, one in Tulare County that Miguel will talk about, and one in Fresno. And so I will say that none of these permanent supportive housing pilots were actual development projects. These are all scattered site, tenant-based, using housing choice vouchers, things like that. So as a pilot, we wanted to get this stuff out quickly, right? Being a part of a development project was going to take a little longer. So, but the idea was the same, right? It is to get our members into a supportive housing environment, provide both the rent assistance and the services, and along with the healthcare, behavioral healthcare, right? And kind of test how it went. So in LA, we did this partnership with the city of Pomona, way out in San Gabriel Valley, eastern part of LA County. Pomona, a pretty big leader in addressing homelessness in LA. Their housing authority, a fantastic partner. We work with the Housing Authority and Volunteers of America, LA. And what the Housing Authority did is basically dedicated a portion of some HUD mainstream vouchers to Anthem members experiencing homelessness. We worked with the court entry system in I think it's SPA 3 in LA, yeah. Any LA folks out there? Did I get that right? Yeah, it's good, okay, yep. And we worked with their court entry lead, it was Union Station. And we did some funky data matching, right? It was like, let's get some spreadsheets and let's try to find members who are experiencing homelessness in the city of Pomona who need supportive housing, who are also Anthem members. So we did some kind of, we did some data matching. And what Anthem really did for this project was provide grant funding to help lease up those vouchers, deposits, application fees. We paid for furniture, so we kind of plugged a little bit of a gap that what the partners said that they needed. In LA County, you got Measure H, you got a whole other set of funding. We didn't need to provide the services. We really leveraged the services that were already in the community in LA existing. So, and so what we saw, after we did this, we housed folks, our members. We saw some good, decrease in ED and inpatient utilization. Stuff went down, right? You've all seen the charts. Things go down when you get people in housing. People stayed housed, did really well. What we did see, we saw some increase in costs in primary care, and our pharmacy costs went up for these folks. Those are good things, right? Those are things we'd like to see. We're okay with that. We're definitely okay with that, right? Our second pilot, I'm not going to go too much in depth because Miguel is going to talk about this one that we did with the Kings Tulare Homeless Alliance. Similar, we used HUD mainstream vouchers from the Tulare County Public Housing Authority, dedicated them to Anthem members experiencing homelessness, used coordinated entry to identify folks. And again, Anthem provided grant funding. When we went to the Alliance, we said, hey, what's your biggest barrier to get these vouchers leased up? And they said, we got no money for application fees. We got no money for deposits. We got vouchers. We got people. We got nothing we just need that little bit. And we said, absolutely, let's make this work. So we provided a grant to the Kings Tulare Homeless Alliance. They did a bang-up job of getting folks and getting them housed and using those grant funds to pay for those things to get people in. Again, and in this one, we actually tried to kind of pair the services with one of our health homes providers in the region. Challenging, health homes was a challenging type program, but that was the intent, to link those folks with services once they were housed. We did see some good impact, right? We saw ED go down just slightly, good drop in inpatient admissions. And the last one I'll talk about really quickly, and the one with Fresno Housing, this one we had a really good idea for it. COVID hit, and I think this really kind of derailed that this project. We're still kind of trying to pick it up and keep it moving. But it was a partnership with Fresno Housing, the PHA there, and WestCare, who is a service provider. In this pilot, Anthem actually provided WestCare with funding for the supportive services, and the Housing Authority was going to dedicate 10 housing choice vouchers to be paired with those services for Anthem members. So, all right, and let me know how I'm doing on time. So, cool. All right, good. So quickly, the second pilot, this was the Housing Flex Fund, and so the idea was that what we heard from our Anthem care coordinators is that they got members who all they need is just maybe a deposit. All they need is 1 month's rent. All they need is something little, right, that to get them either to remain housed or to find a place. And so what we did is we developed we had a large pot of money, right, that LaSar Development actually acted as the intermediary. So they were the ones that were taking referrals from Anthem core care coordinators or community-based organizations for members in need of specific housing-related services and cutting checks, processing those checks, paying landlords. And you can see what we included, deposits, short-term rent, 1 to 3 months, move-in items, arrears, basically anything. I mean, I think we had a couple of requests come in. They're like, can we use the funds for this? We're like, does it help this person get housed? And then they're like, yeah, let's do it. So we made it very flexible intentionally. It was available in all of our counties across the state. And we saw some really good results, right? So we made 110 members across the state over about an 18-month period, got some assistance through this pot. We spent, not an incredible amount of money, almost $220,000. But again, when you look at the average need, it was just under $2,000. That was it, right? A lot of folks, it's not a lot, right? It's not a lot, just $2,000, a person. We were LaSar. I would say we didn't process the request, but LaSar was able to, as they got referrals in, process those payments to landlords within 4 to 5 days, right? Pretty quick turnaround. 2/3 of the folks that received assistance through this fund were actually at risk, and that's something that I think that's something that we're still kind of figuring out and brainstorming kind of what we do with this. Rental assistance and arrears were the most requested items. And I think that kind of goes to that bullet above, right, where folks are at risk, right? Rental arrears, utility arrears, those things like that were the most requested thing to keep people in their place. Again, when you look at utilization data, right, we saw some, pretty good decreases in emergency room visits and inpatient, admissions just by, paying $2,000, a person. All right, pilot number 3. So this was what Samantha will talk more in depth about. This is our housing problem solving, housing navigation pilot. What we did is we contracted with 6 organizations across the state in 6 counties? Yes, 6 counties, to actually go provide housing navigation, housing problem solving type services. Kind of think about street outreach, kind of street-based case management, just, that, and Samantha, she'll describe that a lot better than I can. But really to go out, we wanted to work with local organizations that know the homeless system, know the housing systems in their communities. They are the true experts. Let them go work with our members and understand what their housing situation was, what resources they could get connected to, and support them in that process. And you can see the different counties we did that in and the different organizations that we contracted with. Again, we saw really good outcomes from this. So we served about a little over 200 members across the state. Most of those were actually in Sacramento and in LA. About half of those folks that we served were at risk of homelessness. So those were folks that were on the verge. The outcomes differed immensely by at risk versus, literally homeless, right? So we saw, when we look at folks that were at risk, all of them remained in their house. This was able to kind of keep them there. On the other side, on folks that were actually literally homeless, 19% were able to access permanent housing. That's kind of statewide. Although that seems low. Does that 19% seems kind of low? But in the homeless system, 19%, you know, when you start thinking about street outreach programs, emergency shelter programs, 19% is probably right in that range. Again, saw great outcomes when it came to utilization data, and we saw some really good promising practices from this intervention. Our last pilot, we did some temporary housing programs, made some grant funds for a scattered site shelter program here in the city of Sacramento. We worked with Sacramento Self-Help Housing to create 10 beds of shelter in 2 single-family homes. This is, you know, a shared housing environment. Served about 150 folks. High need population. So we had older folks. We had a lot of people with disabilities, where maybe the regular shelter, you know, system just wasn't the right place. Maybe a room in a house was a better environment for them. And again, going back to that kind of permanent housing placement rates, about 23%, right? That's probably right in the norm of shelter programs. The other program we did was in LA with National Health Foundation, and we did recuperative care. I'm assuming folks are familiar with recuperative care shelter program with kind of wrapped around healthcare needs. You know, a lot of times it's recuperative care is for folks coming out of the hospital who not sick enough to be in the hospital, but not well enough to, you know, go to maybe a regular shelter program. So again, on this one, we saw some pretty incredible utilization data reductions. So 50%, you know, decrease in emergency room visits, 376% decrease in inpatient admissions, right? So well worth our investments here. So what were our key takeaways? The pilots, they really did help us to develop partnerships. I mean, we worked with COCs, we worked with public housing authorities, we worked with homeless services providers. We started to develop those partnerships throughout the state in some of our counties that we're in. Partnerships are possible. I think, you know, a lot of times we've over the years, we talk about, like, you know, partnerships between health and housing as kind of theoretical or like, you know, and pretty kind of vague. But I think these things were very tangible ways that we were, as a health plan, really working in the homeless sector, working in the housing sector, pairing our resources with housing resources, right? You know, kind of putting programs together and interventions together that both met our needs as a health plan, but also the needs in the community. And so a couple of things we also learned is that we need to do better with being a part of coordinated entry systems. We as a health plan, we need to be more involved. We need to figure that out. It was critical to have experienced housing providers do this work on behalf of the health plan. A lot of our pilots serve people who are at risk of homelessness, who may not now be eligible for CalAIM. So what the heck are we going to do with this group? How do we address our membership who's kind of just on the cusp, right? But again, overall, these pilots were critical for our kind of thinking on how we're moving forward with CalAIM today. And I'm going to spend a few seconds. Stefan talked about CalAIM. It's an amazing opportunity. So if you don't know what this is, get familiar with it. How many of you are, you know, affordable housing, supportive housing developers out there? Good. Understand what CalAIM is. How many of you have, if you're developers, have service providers in your buildings that are providing tenancy supports, supportive services, right? Get to know CalAIM, get to know your health plans, right? Amazing opportunities both on enhanced care management, right, which is that kind of care coordination delivered in a person's home where they are at, whether that's on the streets, whether that's in a supportive housing unit. We're starting this. It's live. It's live in Sacramento right now. People are getting referred to these services. So it is a phased rollout starting in January of this year and onward. Quickly, HIP. So part of the Home and Community-Based Services spending plan. This is some federal funds through the rescue plan with some state funding. It is funding that's coming through the state Department of Healthcare Services. I Went for a jog this morning. They're right out there. I saw them down the street. They're giving money to the managed care plans, and the managed care plans are going to have to invest these funds into the community to address homelessness. And so these are one-time funds, $1.3 billion across the state. We don't know what those final allocations yet are for each county. There's talks about it'll be kind of, allocated similarly, like, point-in-time counts and health plan membership. But it really requires collaboration and working together with our homeless and housing sectors, right? The health plans have to develop a local homeless plan for each county. So we're in the process of developing a homeless plan, for Sacramento. But, we're not here to recreate the wheel. We want to work with folks in Sacramento. What are their strategies to address homelessness? How can the health plan how can we use these funds strategically here? How can we fill gaps? And lastly, I just want to talk a couple things on integration of the system. So if you're from a community, you've probably seen a flow chart like this. This is like your homeless response system kind of in any community in America. It looks something like this. Obviously, resources will change. But as we start to think about CalAIM and where these teams start to fit in, we want to start integrating these CalAIM supports and services right into the system. And I think we're just starting this right now, but there's some amazing opportunities to do this. And I think this is where the conversations between the health plans, folks like these two here, with our providers, with our Continuum of Cares, with our housing authorities, with our local, city and county governments, right? We got to start figuring out how these things actually get, integrated well in, because this is things that the health plan can now start to pay for. This is a lot on the slide, but it's an example of some, again, kind of this integration of CalAIM with our coordinated entry systems is something that we want to start thinking about, but it's another good example of how does the health plan really start being part of the local conversation? How do we start embedding these services that we can pay for now into the homeless systems? So our future vision, strong partnerships, truly integrated systems, and improved, overall health. And so strong partnerships, we want to be a part of the discussion. We want to be at the table. We want to be, playing a role here. We also need to continue to build in the capacity internally at the health plans to understand housing and homelessness. So, but the fact that Anthem has some housing folks on the staff, I'm the housing manager for all of California, so that's like one person, right? There's a lot more that I think we can be doing, right, to really build the understanding of housing and homelessness within the health plans too. And I think that requires folks like you all too to be helping out. Data sharing, alignment. These are things we're going to be working on. I really see this number 3, this aligning the services. I think that's like that's the star right there. How do we start really, looking to the future, right? Looking at all this. I mean, there's a ton of money right now to address housing and homelessness, more than we've ever seen before. And so, how do we start thinking about those funds? How do we start thinking about where CalAIM can start to fill in there, right? Partner, home key developments, encampment resolution funds. I've heard in a lot of sessions emergency housing vouchers, right? Those are a lot of communities got these chunks of emergency housing vouchers. That's fantastic. Guess what they didn't get? Services. None of those vouchers came with services. So communities had to cobble together the supportive services to be paired with those vouchers. This is like a dream right here, right? This is so simple, so simple. Those are our pilots we did. And I think the last thing is just really having the health plan being part of this kind of overall community health building, addressing racial disparities, incorporating voices of folks with lived experience, improving health, preventing any homelessness. And I think with that, I'm going to end. I probably went way over time on my side. I'm going to pass over to Miguel.
Good afternoon, everyone. I am so excited to be here, so excited to be in this conference. It's been inspiring, it's been refreshing hearing all the stories and just sharing all this information. And I'm really excited and grateful to be here to share this journey, this story that's specific to our little region. To our area. So again, I'm the fairly new executive director of the Kings Tulare Homeless Alliance. Prior to that, I actually worked for the Housing Authority of Tulare County for about 9 years or so. So this particular program was kind of my baby and what was very involved and hands-on in creating it. And it's one of those success stories that I really try to share with other communities, right? I think about the fact that 10 years ago, in our community, we had 0 housing choice vouchers that were allocated or earmarked for individuals who were experiencing homelessness. We had 0 units that were allocated or earmarked for individuals who were chronically homeless, right? So it was a very, I remember entering this field and feeling very defeated and thinking, what can we do? We need to rethink of how we're gonna address this issue as a region. And I think this conference itself has really emphasized just the importance of building relationships and thinking outside the box, rethinking how we address homelessness, rethinking how we address the housing shortage that we have here in California, how we address the lack of affordable housing. And so I think this journey really kind of speaks on it can be done. So again, our agency also enacts as a continuum of care, and I'm sure most of you are kind of familiar with how continuum of care work. And again, it's really kind of a coalition of different stakeholders, different community members, you know, either local governments, service providers, medical providers, and just a variety of different partners. One of the things that I get excited about when I attend these type of conferences is to speak to developers, right? Because you guys are such a crucial component of really being able to effectively address the issue, which is just the lack of housing, right? How do you solve homelessness? You house them first, and you need those units, but especially here in California. So again, our role as the COC or as the Kings Tulare Homeless Alliance is to really facilitate and share information to empower and build the capacity of our region, of our partners, through sharing best practices, through developing new ways of addressing homelessness, redeveloping systems, looking for more funding, right? And so that's something that we work very hard to make sure that we're allocating as many resources, either monetary or through policy or through advocacy, for our community members, right? Again, we are the representatives. I always tell people that I see myself as the voice for those that typically don't have a voice on the table, or who have other people, or who have other community members who speak louder than them, right? So it's our responsibility to make sure that we're good stewards and representatives for those individuals that have historically not had a seat or a voice on the table. So with that said, we're not a service provider. So we're reliant on building these relationships and these partnerships. So again, not only do we not have the funding, we were out there trying to locate these different resources, but again, we also don't have the capacity to provide the actual services. And we wouldn't want to do that either way, right? Because why duplicate services? Why reinvent the wheel, right? We're extremely grateful that as a region, we have a really strong partnership with a variety of different service providers, which led to this particular pilot program, which led to developing this relationship with Anthem, and it created what I see kind of as the predecessor to CalAIM and HIP and a lot of the different programs that have now come on board. I think it speaks of, again, taking that opportunity and thinking outside the box and just not being afraid to ask, right? I'll never forget the conversation when I get the phone call from the previous executive director, and she's like, hey, let's put together this application for mainstream vouchers. And I'm thinking, there's no way we're gonna get funded. You know, we're a small region. We have 0 to no services or programs that actually have successfully worked to address homelessness in Tulare County. But, you know, let's give it a shot. So I was able to sell it to my board and put together an application, and boom, it came back. So we get awarded 45 vouchers. It's a fairly small amount, but we're excited because, again, mind you, prior to this, we had zero housing choice vouchers that were set aside for individuals that were homeless, that were experiencing homelessness. So as we have this conversation, we're going, okay, let's get this program up and running. We quickly find out what I think we've all known with a lot of the programs that have been developed and implemented by HUD, which there's some essential flaws within the program design, right? So typically HUD likes to throw rental assistance at the problem and thinking that's gonna solve everything else. Or thinking, I'm gonna give you the rental assistance piece, right? We'll pay whatever that amount is to ensure that that individual or that household is not paying more than 30% of their adjusted income towards rent and utilities. But now you have to figure it out as a region on how you're going to be able to provide a holistic approach for the other services, right? And that's when we kind of started trying to think outside the box. And we had a partnership with Tulare County Health and Human Services, and we were utilizing some HSTAP funding to try to get people enrolled. And as we kind of continue with that process, we saw that there were still gaps. That certain individuals were coming to coordinated entry system who were eligible for the mainstream voucher, who were eligible for all the other things, may have not been eligible to HSTAP, right? So you're always restricted when you're working with these programs with the restrictions that come attached to each particular funding source. And so once Michelle Smith, who was the previous executive director, reaches out to me and she says, hey, I had a conversation with Anthem and they're interested in doing this pilot program where they're gonna provide us some funding up front to be able to address some of the gaps that we have. And I'm going, okay, what are the strings? What's the catch here, right? Because you're so used to working in this constricted manner that it really kind of took me back and said, what's the catch? What can we do? And she goes, honestly, it sounds like we can use it for almost anything that's going to allow that individual or that household to find housing. And it was a small scale. I think it was $65,000 that we started with initially, you know, which. And it doesn't seem like it's a lot of money, but for those individuals that we were to help out, it made a world of difference. So again, and then there's this domino effect that happens once you are able to show some success, even if it's small baby steps, right? So we started with an allocation of 45, right? Eventually what that led to was 2 subsequent allocations that Tulare County got because our mainstream voucher program was very competitive in comparison to some of the other regions. And so we got 2 different awards on top of that. We ended up with 134. But again, it really kind of spoke about the importance of that partnership and be able just to not be afraid to ask and really kind of embrace these, what at that time seemed kind of a odd partnership, right? You're looking at a medical provider to be able to work with and address these gaps. But I think, as Chris has noted and explained, there's a direct correlation between housing, between individuals that are experiencing homelessness, and the barriers that come to having access to quality health care, and how can we tie those things together, not only to resolve the issue, but resolve the issue at a much more efficient and effective manner. Even if you're looking at the way that we're spending tax dollars and so on, right? A lot of people are always complaining that, oh, these programs spend so much more money. I think this is one of the perfect examples that we can utilize within our field to say, hey, listen, this is working. This is a way that we can save the taxpayer money, right? And again, so with that said, it was a 2-year pilot program started in 2019. Again, because we were not a service provider, we relied on other agencies to be able to provide the case management, right? So again, one of the huge flaws that usually comes, that has historically come with HUD rental assistance programs, especially the Housing Choice Voucher program, either your regular Section 8 program, mainstream voucher program, and to a certain extent the EHV voucher program, the emergency housing voucher that came as a result of the coronavirus. there's no case management that's built into it, right? So again, it's more of the rental subsidy, and from my experience of working at a housing authority, typically housing authorities are not going to allocate, don't either have the resources or are not willing to allocate other further resources to be able to provide that case management, right? So to them is, once you lease that voucher up, we'll see you at the next annual reexamination or biannual reexamination, and that's pretty much it. You're left on your own, right? And you know, we know that the clients that we work with, the community members that we work with, they need adequate services, right? And so that's been a gap that we have identified for a long, long time, specifically within our area, right? So we knew there was this huge gap, and through this partnership and bringing CSET, which is Community Services Employment Training, into the partnership, we were able to get, you know, not just a continuum of care with the referrals and working through that process, and the housing authority administering the vouchers and kind of being that middleman with HUD. But then you also had, you know, Anthem, this medical provider, and then you had a community-based organization like CSET working and providing case management, and you had this holistic approach of being able to help out these individuals, and not only just getting them housed, but also providing the assistance that they needed, right? Those essential services that they needed to retain their housing, right? It's one thing getting them housed, but you want to make sure that they're able to retain their housing and be able to really transform their lives. So what I wanted to provide kind of just some back, again, we're not talking huge figures here, right? It's a small allocation, so this is kind of just looking at our overall data at the end of 2021. But this is really kind of what I think what's important to point out, right? So the cost per move-in for the individuals that we were able to help out was only about $1,200, right? A little bit over $1,200. Which is not a huge substantial amount. And mind you, our FMR rates in Tulare County are not what you folks see in LA or Sacramento and so on. But it was extremely important to have access to that small bucket of money. Without it, none of those individuals would have been able to move in, right? We had families who, for whatever reason, had no access to the security deposits, and we had no other resources to be able to help out with that. We were able to retain units sometimes because there was a lack of getting that unit to be able to pass HQS or getting that inspection to be scheduled in time. And again, these individuals are, what they need is to be housed yesterday, right? The sooner the better. So again, this type of access to these funds and having the ability to have that flexibility and having the ability to move quickly, right? Because now, we weren't dependent on the housing authority to say, oh, yes, you can pay this security deposit, whatever it may be, right? So we're seeing that, for example, with the EHB, right? So again, this is kind of a predecessor not only to CalAIM, but also to the EHB program. Right? So the EHB program has allocated $3,500 for eligible activity services, which include housing search assistance and other eligible activities, such as deposits, a lot of the things that we were already doing here. But within that process, we have to go back and ask the housing authority, hey, do we have approval to be able to have access to these funds to pay this, you know, this particular funding? And that's when you get into this whole bureaucratic red tape process where it just slows things down. So again, having access to these funds ourselves and be able to move quickly with a partner that is responsive and knows the urgency of it, you know, it made a huge, huge difference. So I think, again, we're at a very exciting time as a COC, as a developer, as a service provider, because I think what we're seeing now with the integration of healthcare into addressing homelessness and housing, it's really this shift from relying on grants, right? So one of the hardest things that I have entering now the COC world and the COC realm of things is that I'm depending on these annual grants, right? And so it's hard to be able to plan ahead. It's hard for me to be able to build the capacity, not only for our region and our partners, but also for our agency, right? Because you're so reliant on these cyclical sources of funding that, you know, we don't, you know, typically, especially a lot of the stuff that's coming down from the state are on a one-time basis, and we don't know if that's going to be available the next year. So to be able to kind of enter this new approach to how we're going to fund these services, how we're going to operate our businesses, I think is extremely, extremely exciting. And I think we all in this industry, even though we may have a different role, need to make sure that we embrace it and really kind of rethink the way that we've done things. Because I think this is an opportunity that I think a lot of us have been waiting for a long time. The expansion of these partnerships have actually led to a street medicine outreach program with one of our local hospital districts, which has also been successful. And we're actually looking at expanding that with some of the other local hospitals within the bi-county area. As a COC, as a nonprofit, again, I would also encourage you folks to engage your medical, your healthcare partners. We're lucky enough to have a member from Anthem on our board, and again, I think it's been extremely helpful as being able to have that input and have that expertise, not specifically for the COC, but I think as a region and for our partners, and to make sure that all the different partners that we have are aware of all the different opportunities that are out there. And again, so just a lot more funding opportunities that are going to be available for our community members, right? So I think looking beyond each entity as the COC or a developer or a service provider, but in reality, these dollars, these opportunities, it's for our community members, right? So I think we got to make sure that we look at it that way, even if it may be scary to kind of step outside of our comfort zone. And again, just extremely excited for CalAIM, just really excited for HIP, and even within our limited scope. So, you know, we're looking at CalAIM. We don't want to duplicate services. We don't want to compete with our service providers. As the COC, we're in charge and administer our coordinated entry system, so we do some street outreach. So we'll be expanding that through CalAIM. But what we're really looking at is to be able to utilize CalAIM to be another resource to be able to fill in whatever gaps we have as a region, right? And so we're having conversations right now with developers. We're having conversations with service providers, and we're saying, hey, let's make sure we're all on the same page that, you know, we're doing the street outreach and we're utilizing CalAIM for that, but let's make sure that, you know, you folks take advantage of the opportunities that are going to be presented to CalAIM to provide services, and maybe that'll allow the developer to create a project that's going to be able to pencil out, you know, that you're going to be able to have enough operating funding to provide the services, right? Because we know that typically, again, you know, sometimes we're able to find the funding for the capital costs and maybe even some operating subsidies, but in terms of actual case management or the case management that is actually required for to be able to properly assist the individuals and households that are going to be residing in those projects, which is typically a higher level, is typically not adequate. So again, this provides another opportunity to have another resource to be able to address that. So again, just extremely, extremely thankful for what that program taught us, and I think I would encourage you all to really pursue this new opportunity that has presented itself here in the state of California, something that I think we all have been hoping for and worked for a long time. So thank you, Chris.
Good afternoon, everyone. So again, my name is Samantha Earnshaw. I am a program manager with Lutheran Social Services. We are a housing program here in Sacramento. Well, we're in a couple of places, as you'll see. So we are a leading provider of housing and support services in 38, and we have 38 programs across 8 counties here in Northern California. And those range from Contra Costa, Sacramento, San Francisco, San Joaquin, Shasta, Solano, Stanislaus, and Yolo. And we serve over 4,000 individuals annually. That's your neighbors in all forms, at risk, homeless, those are your neighbors, from families to individuals, all ages. So one of the things about us as a service provider, particularly in this community, I'm going to be focused on the Sacramento community, which is where I oversee programs, is we've always been conscious of the kind of services that we offer the people who we connect with, our folks, our unhoused, our homeless, are at risk. And we've always been very intentional about the parameters that we work in and making sure that we know how to work within but outside the box. And that sounds crazy, but I'll go into details about that. Because oftentimes the systems, for those of you who work in supportive service, know that the systems are traps and they are not built for success. So it's really up to us as providers to really be creative in how we work to resolve this issue. So our big why is, you know, what if we could help develop tools for our individuals and families that we serve to end the cycle of homelessness and poor health practices for good. And for us, this has been something that we've been very conscious of for years. We're excited, like Miguel was saying, that it's gotten to the point where I felt like the health system has caught up with us. And some of you may feel the same way. Finally, you've seen what we've been saying, kind of thing. So we had the hypothesis, you know, is housing good medicine? We had to put it out there. You know, we have to talk to people. And for us, we had the opportunity in 2014 to partner with Dignity Foundation. And we set up a system where we housed, it started off with 6 individuals, and they wanted to basically do what's being said now, is get those emergency, you know, room and emergency department things lowered. What's the solution here? And they contracted with us, and it's an awesome program. We're still partnered. But basically, they wanted to see, is housing good medicine? Because that's what we sold them. We said, we think it is. We believe it is. What we've been seeing is people who are housed from the street coming to us through the system, and we put them in these apartments, and we put them in these rooms, and they fall apart. And we're like, okay, what's missing in this formula? We're doing what HUD says, for example. Okay, so we've got you an apartment. We're gonna come visit you once a month. We're gonna make sure that you're doing your budget. We're gonna make sure that you're connected to these basic resources, and you should be fine, right? And one thing I learned as time went on, I kept seeing these people, especially old adults, passing away in our programs, housed, supposedly everything is okay, they're stabilized now, right? They have someone checking on them, but why are they dying? And one of the things that I figured, this is what I came up with, I was like, loneliness kills. Loneliness kills. We've taken them out of a community. The streets, they had a community. They had someone who checked, who concerned about their health, who was concerned about their well-being, concerned about them. And then we said, no, 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 we want you here. This is better. 4 walls are better than a tent, you know, this kind of thing. And we weren't really addressing the people. We weren't addressing what was needed. We weren't looking at the big picture. So this partnership was our beginning down that path of saying, healthcare is an important part of what we need to do to stabilize our folks. So I'll go into a little bit of what we do, how we did it. So our how is hands-on in the field, individualized supportive services. One thing that we are very proud of is that as soon as you're connected to us, you're with us. We are with you. Not when you start to get housed with us, but before you even housed with us. We're with you. We're connecting you to services while you're on the street, while we're looking for housing, while we're doing these things. We are with you, holding your hand, engaging with you, engaging with your support systems. If your support systems are also homeless, but not your family, we're connecting them to services so that they don't come and live with you and get you, you know. So it was really a full engagement with our population. Support to obtain affordable permanent housing, obviously, that's our basic job. Measured progress towards social determinants of health, implementation of evidence-based best practices, ongoing access to our team and commitment to support the participant wherever needed, and partnerships, and I'll break those down a little bit in the next slides. So like I said, in the field, outreach and engagement, assessment planning. In that assessment, it's looking at everything, not just what you need, but what do your loved ones need? What are the things that are important to you? Who's important to you? What do we need to examine to make sure that when you start on this path of being housed or being connected, that it's something you'll sustain because it's your plan. It's what's important to you. It's what you're comfortable with. And that goes through with all the rest of it, the care coordination, health promotion, member family supports, and referrals, and of course, ultimately for us, data collection. Support to find that permanent affordable housing, and I just want to make a note that all the pictures that you're gonna see of people are all of our real clients that we've served, and they all gave permission for us to share their stories and pictures. So here you have a youth who's holding up his rifter. We call it the golden ticket, which is his housing choice voucher he was approved for and starting to look for housing. So we utilize these choices, housing wait lists through the Housing Authority or through private developers who have their own wait lists. We make sure as soon as we hear that that building is opening up, we're in there getting as many eligible people as possible on the lists. Obviously the vouchers, everyone's talked about mainstream and the emergency housing voucher and all these other vouchers that are available. We also do shared housing and SROs, single room occupancies. We have a partnership with the SHRA, which is the Sacramento Housing Authority, and John Stewart, which is a property management company, and we have some units that we use there. One thing I just want to make a note about the shared housing is we all know that this is a tight housing market. California is, that's why we're all here. But shared housing is not the fix-it ticket. And I hear people saying, shared housing. I think that we just have to tread lightly with that. And remember, you're dealing with a person who is unique, and shared housing may not work for them. And we just have to respect and be intentional about how we look at people. One thing that we have done is what we call roommate matching. So we make sure that if we're talking to you about shared housing, you're gonna meet the person that you may be roomed with at least a couple of times. And we're gonna see how you engage with each other. You're gonna have meetings with us separately, with your case manager, to talk about how comfortable you feel, those kind of things. That's all important. Yes, it is a housing answer, but it's not the ultimate solution when we're in a crunch. We just have to, thank God, have these partners that are willing to help us be creative with better solutions. For us, Stefan talked about it. We measure our social difference with the Arizona scale, and it was talked about, so you understand. Our best practices, these are them. We're trauma response. We make sure that these are our baselines for operating trauma responsive services, housing first, obviously, harm reduction, obviously, motivational interviewing. But I do have to say that we also don't stick to everything on these things. I look at these as just guidelines. You know, this is not the Bible. We are talking about human beings who have unique needs, who have unique ways of communicating and operating, and who are on different levels of readiness. So, you know, housing first, yes, okay, but once you get in there, there's some things you gotta do to participate as someone who's housed. So there's expectations. I've seen a lot of, I won't name names, but I've seen a lot of organizations who, housing first, and that person is just using, and they're like, no, housing first, and I'm like, ugh. You know, you still have to give some kind of boundaries. You still have to set expectations. You still have to do things that help them get better. It's not just about putting them in a space and letting it go. That's not what it's about. One thing I think that stands out for our organization is our commitment to ongoing support. I think, Samantha thinks, this should be standard practice for all organizations. I understand that we all have different capacities, but I don't care how big or small, and we're a relatively small-sized organization. I don't care how big or small you are, you should be committed all the way to the end and beyond to the people you serve. I just believe that's the right way to operate. I believe that's how you gain sustainability. I believe that's how you build trust. That's how you build motivation. That's everything. I'll give an example of this young man in the picture. He was in our PSH program. He started off in our youth programs and had all the photo stereotypes: dysfunctional family, severe mental health, antisocial behavior, very picky about who he communicated with in the organization, would have angry outbursts. We were just like, we don't know what we're gonna do with this kid. Higher level of care, you know, everything. But when he was good, he was so great, you know? And so we kept working and loving on him and supporting him with tools. He would get engaged with things, so that kept us motivated, because it's a two-way street, and kept going forward. And he aged out of the youth program. And this is the importance of partnerships. So we talked with our CLC and said, he's not ready. He's just not ready to go out there and be independent. It's not time. Can we put him in our adult program so that we give him a little bit more time to get up? In the adult program, he started flourishing. We connected him with our employment readiness case manager. He was connected with a park ranger program for young adults, and he's now fully employed for the last 3 or so years at Yosemite National Park. Independent, got off SSI, bought himself a car, loving his life, living his best life, sending us pictures, you know? So this is it, you know? It's beyond where you think, oh, there's nothing left here. It's just going that step further. I have another former client who was graduated. Now, she graduated out of our PSH. When we say we move them on, you know, you're independent, you got this, let's help you get to affordable, stable housing on your own. She graduated out. She still calls me today to let me know about other housing lists that are opening up so that we can refer our clients. And that just speaks to that relationship. She just knew we're always there. She had an issue with her IHSS hours and work, and she had long ago graduated. She called us like, hey, I need someone to call with me. They're not listening to me, da-da-da-da. Picked up the phone, we're in the meetings. Well, yes, she does need support, da-da-da-da. All the stuff that builds that relationship where they know they're connected to people who care, and it makes people want to do better, you know? Partnerships. I cannot, as an organization, emphasize partnership development. So critical. When, and you'll see, as we progressed along in this idea of health and housing and how necessary it is for sustaining and ending, at least starting to end homelessness, we learned quickly that if you play nice, people treat you nice. We learned quickly how not to be antagonistic. And the best way to not be antagonistic with stubborn institutions, with old institutions that have always done it this way and don't want to hear your new way and your new solutions of doing it, is thinking outside the box and playing nice. And we learned very quickly how to do that. But in general, partnerships for us are important with our clients is our number one partner, obviously, or our members or our folks. Number one partners, their families and their support systems. Healthcare systems, obviously, are important when I talk about the direction that LSS has moved in and that we believe health is critical. So those partnerships are definitely important. Very critical are our landlords and property managers. In a tight housing market, you better be best friends. When I let go of a property manager, I'm pretty sure that that's a disgusting property manager, and I wouldn't want to house my people with you anyway, you know? And that's rare, but it happens, where I tell my team, let them go. We don't need them. If they're gonna treat our people like animals, if they're not gonna take care of their properties, we're not putting our people in slums. I don't care how desperate it is. I'm not gonna tie a client to a contract, which is a lease, where they're tied to a slum apartment when they can move their tent around with no lease and no contract and move to a clean space and move more freely. I'd rather let them stay in that tent a little bit until we find a better place than this. I have no qualms about that. And I think that's what led to us having better partners, because we have better standards for the people we serve. Obviously, the Housing Authority. We need to make friends with those folks. Old institutions, set standards, same processes, no one special. So we learned to play well. And we learned that while we were doing the whole person care program, and I'll explain a little bit more. The COC. Miguel talked about his role as the COC, critical partners for individuals that we know need absolutely additional supports. The COC is a critical partner. And then general service providers, mental health, AOD, SUDS, all these type of partners, legal, you know, that we need to form and we have in the community, employment partners, things like that. And I just want to talk real quick about this very cute picture. This is a whole family, and this family was referred to us by Anthem with the HPS program. They were living in their minivan. Dad had lost his job. They had children. The baby was 4 months at the time they were referred to us. Mom had PTSD. Dad lost his job, so he was probably going through his own stuff. And they had 4 other children under the age of 8. And when we met with the family, in their car, all these babies, all these issues, we quickly were able to connect them to their health service providers, mental health service provider. We connected with a property manager that enjoyed working with us, and he rented them, and we connected them to the voucher. We got them a voucher, and he rented a 4-bedroom house to them, which they still reside in today, 2 years or a year and a half down the line, and are happy. That's a picture that was taken the other day. So that's our happy, big family that we were able to successfully house and connect to services. Our results spoke for themselves. With the Dignity program, which was our first health partner, we expanded from 6 units to 24. This picture is of a gentleman who had been on the streets for, I want to say, over a decade. And that's his legs you're looking at the top. Skin peeling off. That's what we see all the time for the folks who are on the street. And after a year, we've got some nice shoes, we've got beautiful skin, he's happy, he was wheelchair bound on top of it, and he was visually impaired. And so got him housed, and here is health results. This is health and housing. This is the picture of it right here. This is why this kind of partnership is so important. So we applied a lot of our lessons learned from the Dignity program to the new partnerships we were seeking. And one of those was obviously the Anthem Housing Problem Solving Program. And so when we connected, we were like, yeah, we got this, we understand what it is. But working with a insurance provider and a hospital group, very different. So it was an interesting learning curve for us. But as our vision became reality, these partnerships grew. So in 2018, we were connected with, we were one of the 3 housing providers for the Whole Person Care program here in Sacramento County. Learned a lot there, made a lot of partnerships. Prior to this Whole Person Care program, every organization in Sacramento, so while Miguel has a small group where there were no resources, here there's a bunch of resources, but everybody's competing for the same pot of money. So I don't know which is worse. You know, probably yours, but you know, that thing of competing, and we're all supposed to have the same goals, but you're competing for this pot of money, so you're kind of at any turn kind of trying to angle people out so you can get it, so you can get the job done. This forced us to have partnerships in Sacramento. And so we had to play along with each other. We had to get to know. We had to learn each other. We had to speak the same language. We were working with the same people. So that was beautiful. It was a wonderful experience to say, we're not competing, we are partnering, and we're going to do this together. So that was a great experience for us on that level. Then, of course, in the coming years, the Anthem Housing Problem Solving Program came and was working along that program. Like was mentioned before, it wasn't identical. They weren't trying to duplicate what we were doing in whole person care. But it was a good way for us to understand the difference in working with these types of organizations, how different it was. The language was different, the expectation was different, all these kind of levels of structure and stuff like this that is things we had to understand. And we had one staff dedicated to that program. So for us, our experience with the HPS program is that, like I said, we had an opportunity to gain insight in working directly with the health plan. We had to really learn how to get creative because Anthem challenged us. They were like, yeah, we're not giving up things easy. We're utilizing you. You're our partner. We're here to support you to get this done for our members. So we had to really dig deep and get creative and say, okay, we're going to find alternative ways to do this. And actually, I'm thankful. At first, I was frustrated. But, but I am thankful because it actually caused us to find new best practices in-house and also new resources. And thankfully, because we were Care Pilot, we had also new partners. So there are other places we could find resources and things that we didn't have before. Developing a common language. When you're speaking to a healthcare organization versus a social work organization, the language is very different. They're looking at their processes, we're looking at our people. So our job became, how do we match our people to your process? That was big for us. How do we make you see you seeing the member number, we see the member, how do we make us see the same thing? Your needs are important, your processes are important, our folks are important, your members are important. How do we make this one thing so we can make it the best for the member? And then obviously that joins in with developing a common understanding of expectations. So excitedly, it may sound like it was like, oh my God, it kind of felt like that some days. So at the end of the road, when we found out that we had housed a lot, that we led in the number of people who were successfully housed of the literally homeless in the HPS program, we were very excited that our work had paid off. And like I said, our secret sauce was developing excellent partners. That meant within Anthem. Anthem had an awesome care coordination team. And I can name a few now, but wonderful people like Erica, who we stayed engaged with and who was always picking up the phone, always willing to answer our call, always willing to help us advocate for the clients. I'll give you one example. We had a gentleman who was in the HPS program who was visually impaired, he's paranoid schizophrenic, and was living in a motel when we were connected to him. And we were working with him, and he isolates. So he would say, it's not safe for you to come see me. So he would put up barriers for us to be able to meet with him. So we were working with him and trying to work. He needed an ID. We're trying to connect him to DMV and do all these things. And as we're communicating, we realized that the Anthem care coordination team had disconnected him from services because they hadn't been able to reach him. He wasn't answering their calls, so they were like, oh no, we've moved on from this person, they're no longer. And we came back like, wait a minute, we're still working with him. This is why he disconnected with you. This is what's going on with him. And fortunately now, we were able to push him into the CalAIM program through Anthem. So he is reconnected. We're still working with him to reconnect him to services. Oh, okay, thank you. Well, perfect timing. So lessons learned, I guess I kind of spoke about the lessons learned. The language in the medical world, learning that kind of stuff, and becoming adept at utilizing several methods for accessing and recording data, and housing our job. And so with CalAIM, it's early stages. We're learning everything as we're going. And so it's like building the plane. And we're just right now connecting with clients, and so we're learning. Next year you'll have more information on the next one. Thank you.
So I know we are at time, so I think panel will probably stick around for questions after. I don't think we'll probably have time now, but if people want to stick around and talk to the panel, feel free to. We'll stick around and answer any of those questions. But appreciate you all for being here today, and safe travels back to wherever you are going back. Thanks, everyone.